It's my pleasure to introduce to you for our next presenter. We're going to learn about the management of pulmonary artery hypertension in primary care, advancing patient outcomes through improved diagnosis and individualized treatment. Dr. Kelly Chin, who is an assistant professor of internal medicine, director of pulmonary hypertension program, UT Southwestern Medical Center in Dallas, Texas, is going to be our presenter today. So welcome.
All right, good morning. So pulmonary arterial hypertension is a little bit of a difficult topic because we have a lot of different forms of pulmonary hypertension and they're not all treated the same. So I'm going to try today to balance some of the diagnostic workup with the treatment algorithm for those that are diagnosed with pulmonary arterial hypertension. So here's my disclosures and our learning objectives. So I'll start with the different forms of pulmonary hypertension and go through that because that's what really guides our diagnostic workup. And then I will, for the second half, go through the medications, the different classes that are utilized alone and together in the treatment of pulmonary hypertension, and how we decide when to escalate care. All right, so starting with the definition, pulmonary hypertension is defined by a catheterization PA mean above 25 millimeters of mercury. This is roughly equivalent to an echo RV systolic or PA systolic pressure of 40, but the echo is an estimate and shouldn't be used to make the diagnosis. The trouble with it is you're measuring a jet of blood that's going backwards across the tricuspid valve. You square that, multiply by 4, add the estimated RA pressure, and that's the number that you get. As you can see, there's a number of steps in there where error can occur, and I usually add a kind of plus minus 10 to that number, but occasionally it might be plus minus 20. The bigger it gets, the further it's off. So when you see an elevated pressure by echo, you're going to suspect pulmonary hypertension, but you're not usually going to be sure of it, and the definition of pH requires a heart catheterization. Now, in epidemiology studies, they'll generally use echo, and it's fairly accurate on a population level, and I think the numbers are pretty interesting. This is why primary care has to have some interest in pulmonary hypertension. The top 2 studies there are population studies where they did an echo in everybody in an unselected population, and in one, the prevalence of pulmonary hypertension was about 0.5%, so 1 in 200. And then in the Jackson Heart study, which looked at African American participants, otherwise an unselected population, it was 2.6%. This is overwhelmingly going to be either left heart disease or lung disease. The vast majority of these patients don't have idiopathic PAH, but they do have elevated pulmonary pressures, which starts the question of, if you see it in a patient, could they have idiopathic PAH or another treatable form of pulmonary hypertension that we don't want to miss. The rest of the conditions on there are other populations where pulmonary hypertension is very, very common. In bariatrics, these were patients with a BMI above 50. They had heart caths done, and anywhere from a quarter to half had elevated pulmonary pressures. And you can see in heart failure and valve disease, it's very, very high, as many as half to 75% if you're looking at a referral population for transplant, for example. Any underlying disease, once you add pulmonary hypertension on top of it, you essentially generally double or worse the outcomes compared to patients who don't have elevated pressures. So it's something you want to take seriously, but for most of these conditions, you focus on the underlying condition rather than treating the pulmonary hypertension. All right, so there are 5 major groups of pulmonary hypertension. This was an echo study, and you can see the biggest group there far and away is left heart disease. The 5 groups, group 1 is what we're going to be focused on today, pulmonary arterial hypertension. This includes idiopathic PAH, connective tissue disease, congenital heart disease, and a few other conditions. It's uncommon but very treatable with medications that have been approved over the last 20 years roughly. Group 2, left heart disease. Group 3 is lung disease, the second largest group, and then group 4 is chronic thromboembolic pulmonary hypertension, another group that you don't want to miss because of improving outcomes for patients in that group, both with surgical and medical treatment. The full classification looks like this. You don't have to memorize it. Mostly you're focused on getting patients into an individual group and from there narrowing down, okay, what's the underlying disease. But you can see in group 1 a few other conditions that I haven't mentioned. Drug and toxin associated, for example, is important. In the 1990s, we were seeing pulmonary hypertension in association with fenfluramine. Today, we're seeing it in association with methamphetamine and cocaine. The vast majority of patients who use these drugs aren't going to get pulmonary arterial hypertension, but it's a risk factor. So it's something, once I find pulmonary hypertension and I'm seeing a patient in clinic, it is something that I ask about. All right, so just briefly to talk about the other groups that we are not focused so much on today, but which you will see more commonly. So left heart disease, pulmonary hypertension, this is going to be a really, really common one for everybody. And in some cases, you're already going to know the underlying left heart disease, but in other cases, you won't. And you're going to have to go through, does this patient require a full workup for every form of pulmonary hypertension that's out there? And possibly. But in some settings, I don't. So the things I'm going to look for on the patient's clinical history is risk factors for left heart disease. Do they have high blood pressure? How long have they had it? Are they overweight? And so on. And then on their echocardiogram, I'm looking for both definite signs of left heart disease and some indirect markers. And the one that I wanted to point out is left atrial dilation. If you have enough problems with the heart that pulmonary pressures are rising, that happens generally from volume problems and fluid backing up into the lungs. And in order for that to happen, the left atrium usually dilates. Further, if you have other forms of pulmonary hypertension that don't really have anything to do with the left side of the heart, the left atrium often gets small. And so this can be a really helpful differentiating point. You see a small left atrium, you're generally not thinking about left heart disease. You see a moderately or very large left atrium, then you are. Treatment focuses on the underlying condition, although patients with the very highest pressures are being considered for clinical trials in this area or are sometimes treated off-label, though it's not clear how beneficial that is. So I wanted to show a picture of this. On the left, a patient with atria that are not particularly enlarged. This is a patient of mine with mild pulmonary hypertension, but you can see relatively small atria compared to the ventricles. On the right, a patient who had heart failure with preserved ejection fraction and has marked biatrial dilation. So this is generally either going to be quantified as a left atrial diameter or volume, or sometimes just a qualitative read, moderate or severe left atrial enlargement is what I'm going to be looking for. All right, moving on to group 3, lung disease-associated pulmonary hypertension, so our second most common form. This one is generally not as subtle. Most of these patients where we find pulmonary hypertension have known late-stage COPD or pulmonary fibrosis, and they're very hypoxic. The pulmonary pressures correlate better with low oxygen than they do with lung function, but it frequently all goes together. So you'll have severe obstructive lung disease, severe hypoxia, and particularly in this area, sometimes a patient who doesn't like wearing their oxygen. And we know now that that makes a big difference for patients. So on the, oops, I went the wrong way. Let's see. On the right here is the NOT trial, which was a nocturnal versus continuous oxygen study that was conducted back in the 1970s. And what they found was the group that had low oxygen levels and was randomized to wearing oxygen continuously had about half the mortality as the patients who just wore it at night. Importantly, they also did a heart cath in this study. They did a baseline and a 6-month heart cath. The patients randomized to wear oxygen continuously, their PVR went down. The group that wore it just at night, their pulmonary vascular resistance went up. So far and away, first-line treatment for pulmonary hypertension in the setting of lung disease with hypoxia is oxygen therapy. Fourth group, chronic thromboembolic pulmonary hypertension. So this is going to occur mostly in patients who have a history of pulmonary embolism, but about a third of the time they may not. They may not have sought medical attention for it and so on. And we use both VQ scan and CT scan to screen for this in pulmonary hypertension. We actually still favor VQ. It's one of the few areas where VQ is still better than CT in many situations. The problem with CT is that the clot is often no longer completely obstructing a vessel. It may just be lining the vessel or have shrunk the vessel by scarring. And so it still looks patent, especially to a radiologist who doesn't see a lot of chronic thromboembolic PH, where the VQ scan is usually quite abnormal, although as it's being used less frequently, we see some misreads occasionally there as well. All right, so those are the three forms of pulmonary hypertension that we're thinking about when we're working up a patient who we say, you know, we think this patient might have idiopathic PAH, but that's a diagnosis of exclusion. I'm going to look for left heart disease, lung disease, and chronic PE before I'm going to more seriously consider that diagnosis. And as a result, there's a long list of tests that are typically done to work up pulmonary hypertension. This is from the US guidelines. And you can see the required tests there on the left. The other tests that are shown here or that were shown are tests that you can consider if you find more unusual abnormalities with this basic workup. And these are just trying to do what I just said. Look for left heart disease, look for lung disease, look for chronic PE. And it's the 5 tests with a star next to them that are considered the pivotal ones. So echo, BQ scan, lung function test, overnight oximetry, and a right heart catheterization to confirm the diagnosis. And then CT scanning is not on this list, but I would do one in the patient who had a significantly abnormal pulmonary function test or an abnormal VQ scan I would use to help put that information together. However, that's a lot of tests, as you can see. And as I was talking about at the beginning, as much as 1% of the population may have at least slightly elevated pulmonary pressures if we go do an echo on them. Does everybody really need these tests? So the Europeans in their latest guidelines actually said, you know, maybe not. We think that we can look at it as if a patient has known significant left heart disease or known significant lung disease, and the pulmonary pressures aren't that elevated, and we don't have signs of right heart failure, which is a very concerning finding when we see that in pulmonary hypertension. Those patients, we may not want to do all of these tests, focus on the underlying condition, and continue to follow by echo. If the pulmonary pressures keep going up, sure, we may want to go back and do that, but otherwise we can do a more limited workup. Whereas the patient thought to have group 1 or group 4 pulmonary hypertension or pulmonary hypertension of unknown cause, you don't have known left heart disease or lung disease, or even if you do, but the pH is particularly severe, that patient may need a full workup. So that severity, you know, the pulmonary pressure is a fairly obvious thing. I can say, okay, if the pressure is less than 50 or maybe 50 to 60, we can call that relatively mild and perhaps what one might not find too out of proportion in a severe lung disease or left heart disease patient. But what do I mean by right heart failure? So basically, it's looking at the right side of the heart at both its size and function and the tricuspid valve, how regurgitant is it. So on the left, I have a patient with pretty good heart function. On the right, I have a patient with terrible right-sided heart function. The right atrium is very dilated, left atrium is all squished, the right ventricle is very dilated, and there's a pericardial effusion present. What you're going to look for on the report is either a qualitative or quantitative measure of right ventricular systolic function. Is it moderately or severely reduced? And size. Is it moderately or severely enlarged? In which case, even if the pulmonary pressure is just mildly high, that RV dysfunction pushes you into the category of more concerning pulmonary hypertension that needs more of a workup. Okay, so how do we put all this together? So I thought I would take a case of a patient that I saw recently. This is a 45-year-old woman who has scleroderma, so has a risk factor for connective tissue disease-associated PH, and she comes in presenting with dyspnea on exertion for about 6 months. She's still fairly active. She can go to the grocery store, walk in from her car, but she's noticing some shortness of breath when she does that. On exam, you would likely hear a loud P2. That one's kind of hard to hear when you're listening to the cardiac exam, but she actually has some other more concerning signs. Her neck veins are elevated, and she has some lower extremity edema, which can indicate right heart failure. We do pulmonary function testing, and it shows some mild restriction. We'll come back to that in a minute. And we do an EKG, which shows some nonspecific ST changes and a little bit of her right axis, but nothing that we're going to make a diagnosis of. And on chest X-ray, her heart and pulmonary arteries are a little bit enlarged. So some suspicion for pulmonary hypertension, but there's still a lot of other things that this could be, and we're going to need to continue the workup. So next up, we do an echocardiogram. We want to see what her estimated pulmonary artery pressure is, and her echo, unfortunately, looks terrible. She has an estimated RV systolic pressure of 95, so very, very high. Her right heart is dilated. It's not working as well as it should, and I have a second picture that shows the heart in cross-section. You can see just how compressed the left ventricle is. This is one of the reasons why volume is often harmful rather than helpful in these patients when they get really sick and come in hypotensive. You give fluid, and the RV just gets bigger, and the left ventricle can't fill. It's so squished. So echo looks terrible and suggests pulmonary hypertension. So coming back to her lung function test, scleroderma patients are also at risk of interstitial lung disease, but her chest x-ray really doesn't look that bad. I would get a CAT scan in this case, but I would also say this is not pulmonary hypertension from lung disease. We included in all of our clinical trials lung function down to about 60% predicted, so this patient would likely still actually even be clinical trial eligible as a group 1 PAH patient based on what we have so far. We also measure oxygen saturations at rest with exertion and overnight. We're very focused on keeping oxygen up because it's an additional problem for the patients who are hypoxic, but in this case, even if she was mildly hypoxic, I still would be considering her likely a group 1 patient. All right, as we do in everybody, we do a VQ scan. This is hers on the left. This is where it gets a little bit difficult. That's a low prob scan, but you can see there's a bit of irregularity there. Sometimes these will be read as intermediate probability and you're not sure what to do with it. Chronic thromboembolic pH, though, 95% of the time they're going to look more like the one on the right. They're going to be very, very high prob with numerous defects all over the place, and it's not subtle. So if there was any question, one can go ahead and do a CTA, but I would look at this scan and say, this doesn't look like chronic thromboembolic pH, particularly not pH of her severity. There's just no way that she has clots in enough vessels to cause really severe pH like we're seeing on her echo. All right, so then our final test is going to be heart catheterization. So just going through the definitions that we're looking for there. So we suspect pulmonary hypertension by her echo. We actually really, really strongly suspect it because not only does she have high estimated pulmonary pressure, it's really high, and her right heart is failing. So I would be shocked if we got to cath in a patient like that and the pressures aren't normal. But we still do it both for prognostic reasons and as a final check to make sure that the left-sided filling pressures aren't high because left heart disease is so common. We want to make sure that we're not going down the wrong pathway for treatment. So we're looking at cath to confirm pulmonary hypertension in general, that's the PA mean above 25, and then to exclude left heart disease. So we're looking to see a wedge pressure that's below 15, which would be consistent with pulmonary hypertension that's not from left heart disease. It doesn't tell you what it's from, that's what all of the other tests do, but it just says not the pattern we expect to see with left heart disease. So here's her heart catheterization. PA pressure is 78/40, mean is 53, so a little lower than we got in the echo, but still plenty high. And her wedge pressure is 8. So this does not look like left heart disease pH, and in the setting of all of the other tests that she's had done, this would be consistent with group 1 PAH. So we've looked for left heart disease with the echo and the cath. We've looked for lung disease with chest x-ray lung function, and probably CT. Even a little bit of lung disease still doesn't put you in a different category here. We've done a VQ scan, and then we have the known history of scleroderma. So now moving on to how do we treat this patient. So prior to the late 1990s, there weren't any therapies for pulmonary hypertension other than calcium channel blockers, and they hardly ever worked. They basically don't work at all in connective tissue disease, so there's no point in even thinking about it, and they work in probably around 5% of those with idiopathic PAH. And we can figure out whether they're likely to work or not during the heart cath. In the idiopathic patient, we do a vasodilator challenge. If their vessels dilate enough that the pressure drops markedly, then they can be treated with a calcium channel blocker. Otherwise, you don't want to try it because all you'll do is make the patient hypotensive, and that may in some cases be fatal. If their pulmonary vessels look like this, where they're just all kinds of abnormal growth, proliferation, and scarring, they can't vasodilate that. That's just not going to happen. Their systemic pressure is going to drop, and they can't increase their cardiac output to keep up with it, and it can be very dangerous. So instead, what do we have? So investigators found a number of other pathways that the medications do have some vasodilatory effect, both on the systemic vessels and pulmonary vessels, actually. But what they also have is anti-growth effects. So in the lab, these will, on pulmonary artery smooth muscle cells and endothelial cells, have anti-proliferative effects, and at least in animal models, reduce the vascular remodeling that we see in pulmonary hypertension. It's hard to show in people because we don't go doing biopsies a lot. And the three pathways are shown here. So there is the endothelin pathway. Endothelin causes vasoconstriction, and we have antagonists to that. We have the nitric oxide pathway, which promotes vasodilation and is antiproliferative, and in that pathway is where Viagra and Cialis, sildenafil and tadalafil, are, as well as a new class of medicine that acts a bit earlier than the phosphodiesterase. You can see right at this, very well, where it says soluble guanylate cyclase stimulator. So there's a new medication that acts on that and also promotes this pathway. And then our third pathway is the prostacyclins, and we have both prostacyclin itself and agonists and a new medication called selexipag that binds to the IP receptor and promotes that pathway. Here are the names of these medications. So selexipag, I think, actually has kind of a cool name. It is a selective IP receptor agonist, so they actually built its mechanism into the name of the medication. But those are all of the prostanoids, and that's our class of medications that still has the most variability in how these medications are administered. You can see the patient with the pump there. That's for IV epoprostenol or treprostinil, which are infusions. This is still our most potent medication and is used in our sickest patients. And actually, the patient that we discussed in the case would probably be a candidate for that type of medication. Because that's inconvenient, there are other medications that have been developed that are either inhaled or oral, so selexipag and treprostinil are oral prostacyclins, but they aren't as potent as the IV medication. So they're useful in patients not sick enough to need the IV medication, but we still haven't come up with anything that's as good. The other two classes of medication, the endothelin antagonist, and then in the nitric oxide pathway, the PDE5 inhibitors and guanylate cyclase activators are the other types of medicines that we use. And a big question has often been, well, how do you decide which one to start? You know, other than IV therapy is for our sickest patients, amongst all of the other choices, how do we decide? But that question is actually, it's important, I think. However, increasingly, the answer to that is you actually probably want to start more than one or fairly quickly get to more than one in a pretty high percentage of patients. And we fortunately have a lot of studies looking at different ways to put medications together for those who had an inadequate response to their first medication. And what we found is that it does appear to be beneficial to, in the patient not responding adequately, to add a second medication from any of the three classes. And this appears safe to do, although as you add on 2 and 3 medications, you can get some systemic hypertension, so you watch for that. The only exception to that is the 2 medicines that work on the same pathway, the PDE5 inhibitors and the guanylate cyclase activators that both work on that nitric oxide cyclic GMP pathway. You don't want to put those together because it's too much. It lowers blood pressure too low. They tried that in a clinical trial, and it caused more harm than benefit. So deciding how to do that, the current guidelines read like this. For the patient that's newly diagnosed, we use diuretics if they're volume overloaded, oxygen if they're hypoxic, and we are increasingly not using anticoagulation. It was never studied in a randomized trial, but there's various observational studies that have both said yes and no to that question. You test for vasoreactivity for the idiopathic patients. A very small number of them may be treated with calcium channel blockers then, but everybody else, you continue on with the algorithm. And in the low to intermediate risk patient, would generally start with 1 or 2, and I'll show you the data for that, oral medications. For the higher risk patient, you would start with an IV medication, usually in combination with one of the oral medications. If they have an inadequate response, which you want to check at 3 to 6 months, then you can add another medication up until all 3 classes of medication are being given. And if they still have an inadequate response, then transplant referral is considered. So the studies that really pushed us towards this combination approach, for a long time, all of the studies in pulmonary hypertension were 12 to 16 weeks, vast majority at least, and the primary endpoint was 6-minute walk. And these studies also showed benefits in other areas. Hemodynamics improved and symptoms improved, but they were very short. And as we started doing add-on therapy studies, the improvements seemed to be smaller. So there was some question about when you add 2 medicines together, how much of an added benefit do you get? But that question was really put to rest once a few longer-term studies were done. The study on the right, Seraphin, took patients who Mostly were on background therapy. About 2/3 of these patients were already on a pH medicine with an inadequate response. About 1/3 were not. And they added macitentan, which is one of the endothelin antagonists, and looked at long-term outcomes. And they saw a marked reduction in clinical worsening with that, both in patients on background therapy and not. So this, along with a number of other combination studies, got us to the point of saying, if you have an inadequate response, definitely think about adding therapy. The study on the left took it a step further. This is Ambition, and they took newly diagnosed patients and randomized them to 2 medicines right up front versus either ambrisentan alone or tadalafil alone, and they pooled those 2 monotherapy groups together to look at it. And they saw a 50% reduction in clinical worsening with this approach, and in sub-studies also showed much greater improvement in hemodynamics. There were fewer hospitalizations, hit pretty much all of the endpoints that they looked at. So fairly impressive, and to the point that at this point in time, most patients that I see newly diagnosed in clinic, I'm starting on 2 medications. We do a risk assessment at the beginning, and we also repeat this after 3 to 6 months in deciding whether to add on therapy. And the most important findings are going to be symptoms, how short of breath, what's their functional class. Walk distance, remember our patient in the example had a walk distance of 300 meters, which would be in the intermediate risk range there. Echocardiogram, NT-BNP, and cath. And the NT-BNP levels, our lowest risk patients are going to have a normal or near normal NT-BNP. Our highest risk patients have very high values, often above 1,000. On echocardiogram, the lower risk patients have normal heart function, normal heart size. The pulmonary pressures may still be high, but the heart size and function has come down to near normal sizes. So for our patient, she would have had mostly intermediate risk findings, and we could consider either IV therapy, particularly because she's so young, or upfront combination therapy, and then after 3 to 6 months, we would reassess and then make a decision about whether to add an additional medication. So the next 7 or 8 slides are in your handout. I'm not going to go through them individually. They list each drug, the dose, and indication. And for those that have special considerations, this is listed as well. And there is a slide on adverse reactions and drug interactions. So for the when to refer patients, the European guidelines and the US guidelines differ a little bit there. Their approach is actually all patients with unexplained or group 1 or 4 pH should be referred to a pH center. That's not necessarily practical in the US. Some patients are 5-7 hours from the nearest pH center. What the US guidelines say is if treatment is undertaken locally with not at a pH center, after 3 to 6 months, if you still aren't achieving those low-risk features, then to consider referral to a specialty center, particularly because at that point an IV therapy may be considered. So take-home points from that. Pulmonary hypertension is very common on echo. It most often occurs with left heart disease or lung disease, but treatable forms you don't want to miss treatable forms, and so a full workup is very often going to be required. Further, some patients with left heart disease and lung disease, however, if you have mild pulmonary hypertension with pressures that are not very high, right heart failure is not present on echo, some of these patients' treatment can focus on the underlying disease with serial echocardiogram. And all patients require heart catheterization before embarking on treatment because a full workup is needed to be really certain of the diagnosis.
Thank you so much, Dr. Chin.